pressure, high filtering pressure, and with the glomerular damage, there will be excessive filtration. So because of all that, you can get red blood cells leaking into your urine, and that can appear as hematuria. So that's one thing. And then you get systemic ones. So systemic ones is not concerned only to the kidney as an organ per se, but it's like a generalized thing, like a bleeding disorder. So it's not only hematuria. You can bleed from anywhere. Like you can get hematemesis, or you can get you can get bleeding from cuts, bleeding from wounds, or those bleeding disorders which we know, hemophilia and all those things. Or else it could be something like a drug. So drug also doesn't act only on one place. It can act on everywhere in the body. So it's called a system. So we are mainly concerned about the urological causes of hematuria. So one important thing you need to know in urological causes are, in contrast to the nephrological causes, here you can get a normal red blood cell morphology, because here it's nothing to do with the glomerulus. So the red blood cell, it is not subject to any damage or any stresses from the outside nephron. So what happens is red blood cells just simply leak out of the blood into the urinary tract, and what you see in the urine is called hematuria, basically hematuria, red urine, blood-stained urine. So since we know that, so basically you can either divide it into non-visible or visible hematuria. Now, of course, you don't call it microscopic hematuria. The reason is because now with the recent advances, now they have developed the dipstick. So apart from not looking in through a microscope, you can still detect the non-visible hematuria. Hence the name non-visible, not microscopic. And for microscopic hematuria, you need to have more than red blood cells per high power field to call it actual hematuria. And then on the other hand, you have visible hematuria. That is the hematuria, like in other words, what you see to your naked eye. So that's what you see from catheter bags draining into the catheter drainage system. That's of course a microscopic hematuria. And then if you take the age category into account, you can classify. I mean, you can't always say kids have glomerular causes, young adults have stones. But then this is, I took this obviously from Ranga sir's note. And what he says is, kids usually have glomerular causes like nephritic syndrome and all. They present as hematuria. While young adults, the most common cause is stones, urinary calculi. It could be either renal calculi or ureteric calculi. Anyway, once it erodes the epithelium of the nephron, it can cause bleeding. And whereas what we are concerned mostly, and what we see in our day-to-day long case, and what we see in the wards are middle-aged or elderly patients who usually present as a urological cancer. That's the hematuria is a presentation of an underlying urological. That could be either renal or a bladder CA. Okay, so since we know the thing about hematuria, the general idea, let's see how we go for the long case. First of all, I'll do the long case part, the history taking, and then I'll go on to the investigations and the management. So that is easy. So it's more practical that way. Okay, so yeah. So if I'm going fast at any moment, just let me know. Okay, slow down. So first the long case. So first of all, the presenting complaint. In this, never mention blood, because now the patient, even though he himself says, Dr. like you don't always know it's definitely blood. No? So never mention that it's blood-stained urine in your history. Always mention is red-colored urine, because there's no harm. And the examiner also knows that you actually analyzed it late in your history of presenting complaint. So just stop it there, because you never know. And then when you go on to the history of presenting complaint, there, of course, you can describe it more in detail. So first of all, you can say the onset and the duration. So usually short onset, like, sadly, let's say like, like or something like that. So then you can suspect, let's discuss later on how to exactly come to the cause. But then you can, like, generally you can think it could be something like colic or a UTI, or if it's a very short duration, like suddenly, you get a lot of, you pass a lot of red urine over a short period, then you can think of CA as well. Whereas if it's a long duration, like, and it doesn't really affect the patient much, it could be something like BPH. But then again, like Ranga says, this is not a useful distinction to, to determine the pathology, because it could be vague. Some patients, even though it might be there for a long time, they may notice it only like recently. So they may say it's a short duration. So never rely only on that, but then it's a useful point. Okay, then the progression. Here also, it's not a very important point, because like once the blood vessels are eroded, because now like, the hematuria comes because red blood cells leak from the blood into the urine. So whenever there's a blood vessel within that tract, even if there were like, like 10 red blood cells today in your urine, and tomorrow also it will be like almost the same number of red blood cells leaking, right? If at all, it will be less, because the body naturally heals that eroded epithelium. So again, progression is not really a very important thing in your history, but then it's always good to mention it, whether it increased or decreased in color. And then the site. Here also, This is something like Rangavikis, sir, he really doesn't like even when we mention the site, because what he says is when tells you the history, you can't really, like, even though he says like initially it will be red, later it will be red. Like when you really talk to a patient, Sri Lankans always have a way of exaggerating things, right? Even though if it's at the beginning, they'll be like, nah, doctor, mulu ekema gaya. So again, it's not like a reliable thing, but then theory wise, I mean, if it comes to MCQ or something, it will be always be good to know that at the start, if you get hematuria, that is usually urethral in origin. While if you get it terminally at the end, it is usually due with the bladder trigon, because that's the part of the bladder which drains the last when you urinate. So that's why you get terminal hematuria in bladder trigon pathology. Whereas if you get it throughout your urinary stream, it's most likely to be due to something with the bladder neck or kidney. Why bladder neck is because now when the sphincter relaxes, the first part of it, the first part would be the urine in the bladder neck. From there on, it will go on, it will be diffusely in the urine. So therefore, you get the red color diffusely throughout urinary stream. So, and also it could be a kidney pathology as well. So, theory point of view, okay, it's good to know, but then practically you can't really, rely again entirely on these three things. And something which Rangasa mentioned in one of his lectures was that when you call it clinically significant hematuria, that is the two things. Either it is present throughout the stream or you pass clot colics. In other words, you see red color, or not always red, but then kind of, part and passage of, like part things going through your urine. So those are called clot colics. So usually they're painful. The patient will tell you that it's painful when the urinate. It's usually you had a suspect something like a clot colic. Okay. So that's when you call it clinically significant hematuria. Then moving in the history of presenting complaint, painful or painless, you must have heard definitely, painless hematuria is always CA, KLA, you must have always heard something like that. But then it's actually not true all the time. That is because if I first talk about painless, because that is more clinically a long case, it could be renal cell carcinoma. But Sir says sometimes can be painful because of that earlier mentioned clot colic. So to explain how a clot colic forms, basically now when the bladder fills with urine, it will stay for some time, right? Because the patient passes urine every 3 to 4 hours, so it will stay stagnant for some time. So if there's an amount enough to concentrate and form a colic, it will form a colic in the bladder. So when you pass it, it will not just be painless, you will actually be painful because you're in that particular clot colic as well. So that's why you can't rely on this distinction, because painless hematuria is not always renal cell carcinoma. It could present painful as well. I mean, in a way, you can actually be asked that for an MCQ, because it will be, the bird will always will be there. So if it's always painless, it's actually false because it could be painful. And then bladder CA, of course, is usually more painless compared to renal cell again, but you can't really say, because again, it can pass clot colic, so it can be painful again. And upper tract ureterial carcinoma, and then which is a less common cause, and then finally BPH. So BPH is a more benign cause of hematuria, but it can present with torrential bleeding because like the blood vessels around the hyperplasia, the prostate which has undergone hyperplasia, they're very fragile. So if something erodes it, it can definitely bleed a lot. So that's why you get something called torrential bleeding. It's like massive hematuria. And then if you talk about painful causes, you have to the first thing to suspect is ureteric colic. One thing is because it's very common. Other thing is because the history will be quite classic. So one thing is a radiating pain, the loin to groin, which we all know, if it's a ureteric colic. And then the ANA symptoms, autonomic nervous system, like, vomiting and all that will be with a ureteric colic. And also it's very highly suggestive if the patient has a past history of ureteric colic, because someone who has ureteric colic once will actually have a higher tendency to get it repeatedly than someone who didn't have it at all. I mean, when I think someone will be doing a class on calculi later on, so y'all will get to know more about that. So I'll not touch much about that. And then UTI. So UTI is again very less likely in adults. UTI is common in children because of the hygiene practices and all that. So UTI is again one of the other less differential causes you have to consider when it's painful hematuria. Okay. So right, that's painful and painless. Then you come to the main two pathologies that's concerning hematuria. That is renal cell carcinoma and bladder cell carcinoma. So in renals, just give me 1 minute. Right, y'all can hear me, right? I'm not very clear, right? Okay. So in renal cell carcinoma, So you have to ask about this. You can basically categorize both of these into symptoms and risk factors. That makes life much easier because then you don't need to like memorize so many things. If you just remember this classification, I don't know, I found it quite useful. So I hope it will be. So symptoms you can ask, one thing is due to the tumor, and the other thing is due to the spread. Other things due to the paraneoplastic syndromes. Renal cell carcinoma, as you know, are very like popular because of the paraneoplastic syndrome. It's like that's the like standing out feature for renal cell carcinoma. It's not, I mean, you get those in lung cells, small cell carcinoma, the lung and all that. But then out of the pathologies we talk in surgery in a final year, like they talk about paraneoplastic syndrome mainly in renal cell carcinoma. So it's always good to know that. So due to the tumor, if we take symptoms, one thing is you can get this flank pain, obviously, because it's a tumor, it's something growing inside your abdomen. So it's not just going to stay there, it's going to cause pain. So you can get a flank pain depending on the side, which is right side or left side of the tumor, you can get a pain there. And then obviously, because there's a mass, once you do the, I mean, even though I put this under history line mass, you can actually, even though it's like an examination finding, you can actually mention it in your history if the patient says it. But if the patient does not say, it's always best, like you can say that loin mass, which the patient claimed that he or she didn't have. So you can always say that you excluded it, but then if the patient does not say that he has a loin mass, don't go and say, he had a loin mass, because most of the time, the panel won't go and, ask the patient again, but then it's always, good to say only if the patient says. But, and also, these three made the classical triad of renal cell carcinoma: flank pain, loin mass, and hematuria. That the triangle you remember. So, but the thing comes only in very locally advanced hematuria, not the very early stage. So actually, Circos is the too late triad, even though it's the classical triad, because for you to get these symptoms, it should be quite advanced. And then you get the spread from the tumor. So the lower limb swelling, I mentioned it is because now, as you know, the renal cell carcinoma, it has a very special feature where it can invade the renal vein. So once it invades the renal vein, it can go and involve the inferior vena cava also. So when it does that, like in any kind of pathology, when something obstructs the venous return, it will obviously call edema below that, right? So that's the same thing which happens here. Due to the tumor invasion into the vein, it will include the IVC that causes lower limb swelling. So if the patient presents with that, then before you do the investigation, of course, okay, maybe this patient then has not a organ confined tumor, maybe he has much more pathology, like it's locally advanced. So that's the importance of knowing lower limb swelling. And then left side is floral swelling. Or these two also, I mean, technically, these are examination findings, but then if you can, mention that if the patient says, or if you can say that you asked for this, it's actually good. So let's try to mention this. And then the paraneoplastic syndrome, I said earlier. So they have like a variety of presentations of paraneoplastic syndromes. So other things you can ask in your history are anemia. So the shortness of breath on exertion, and those things you can ask. And then hypertension, of course, you can't really ask much in the history. So, I mean, blood pressure finding, but then you can ask about, headaches and, visual halos and stuff like that. Then again, not very specific, it's quite vague, but you can ask. And hypercalcemic features, those are like all these actually vague symptoms. You get hypercalcemic, you can cause lethargy, weakness, nausea, vomiting. So, you can just mention it. So in that, you know that you're asking for this scale, you can show it to the examiner. Okay, so those are the symptoms. Then the risk factors, not a lot, only you can ask about smoking, which you can include in the social history or here, either thing. I usually prefer including it here itself so that, I can complete this entire renal cell carcinoma and move on to the next one, but it's up. You can mention it anywhere. But if you mention smoking, since this is the other thing. Now in surgery or in any, like, I'm not sure if some of y'all have more than surgery. So if in any subject, if you're talking about the certain risk factor, which is particular to that pathology, always like go into detail about that. But then if you're asking smoking and maybe something totally irrelevant, like, something doesn't come into my mind, I just remember smoking is not a risk factor for something, don't go on to detail like of mentioning smoking. But then here, of course, you can say the number of smoking, the pack years he had, and all that you can mention here. But then if it's just a normal risk factor, no need to go into town about that. Okay. And then occupation also you can mention the petrol sheds, petrol, paint, asbestos, these all are risk factors. So you can mention that. And the family history. Family history is because renal cell carcinomas again known to be familial. That VHL disease and stuff like that, they are familial syndromes. So it's always good to mention this is the family history. So that's for renal cell carcinoma. And then you go on to bladder CA. So bladder CA again classified into symptoms and risk factors. So symptoms are you can get due to a tumor, that is the obstruction of the tumor itself. So the bladder will outflow, obstruction will be happening. So the BOO symptoms. So the BOO symptoms occur because of the bladder the tumor obstructing the bladder outflow. So because of that, you can get franchiry. Franchiry is one of the classical symptoms of bladder CA, which if, of course, if you get Rangavicasa, he will definitely, wait for this word for you to say that the patient, don't mention this word, okay? Just mention, the patient complains of a painful desire to urinate, which is usually not productive. Like when he wants to urinate, he tries to, it's painful at that time, but he never passes urine. So you can mention franchiry in that way, but don't mention the word franchiry if you, I don't know whether he like it or not, but better to say it in words. And then irritative lots again because of the tumor. Irritative dysuria and those things are increased frequency. Those are because each time the bladder wall gets irritated, it will try to leak out urine. So you get those. And the boo symptoms, which I told earlier, the obstruction and hesitancy, and fleshy particles can sometimes the patient might say, okay, doctor, මට මෙහෙම මේ මාස් වගේ මේ පොඩ්ඩක් ගියා මොකක් හරි එහෙම කියලා, like they can say something. That's because actually the tumor is very fragile, so it can break off while within the bladder. So when that happens, it will pass out in the urine. So fleshy particles, it will always not be the tumor because sometimes it could be a clot colic also. So you have to always be aware that it's not always a tumor which can go, it can be the clot colic, or else sometimes we'll talk about it later. If it causes fistulas with the the posterior rectum, it can cause fecal urea also. So because of that, you can get fecal matter also passing out through the urethra, which they'll complain as fleshy particles. So if sir asks about this, you can try all those three DDs, that is clot colic, the bladder tumor particle, or the fecal matter, all three to be fleshy particles passing in the urine. Okay. And then recurrent UTI also, if it's a fistula forming with the rectum, easily, bacteria and all can come into, which is usually sterile. And so it can cause UTI. Okay. And then spread pneumaturia kiyanne. Now our sir says, like some students, what sir says is like, some they say like when you are, how do you call it? Like you have to only call it pneumaturia when you say air bubbles at the urethral orifice. Not just because of anything else, because just because you were past bubbles in the urine doesn't really mean it's pneumaturia. It should always be the patient has to like see that actually had bubbles coming out of the urethral orifice. That is when you call pneumaturia. So that's an important thing to keep in mind. Pneumaturia is that. Then risk factors again, like renal cell carcinoma, smoking, the long-term catheterization, and Middle East and Africa travel. Those things are for squamous cell carcinoma, the last two. Smoking, of course, is for adenocarcinoma as well. So just remember the risk factors, like have a vague idea of what are the risk factors. Okay, so that is the main thing about the history. And then, hold on. 1 minute, guys, is like X up sometimes. It takes it. Sorry, guys, just give me a minute. I think the screen froze a bit. Okay. Right. Sorry about that. Okay. So then you go on to metastatic symptoms. So here, the LLBB, the lung, liver, bone, brain. So the common, in any cancer, you ask about this, so you can ask about those symptoms. The early morning headache, the yellowish discoloration, the bone pain, and all that. And those things, that. Then the past medical history. So past medical history, again, like earlier when we mentioned that there could be systemic causes and nephrological causes. At the quota, you have to mention that in one statement itself, you can mention, this person does not have any other comorbid disorders like hemophilia, platelet disorders, blah, blah, and you can just finish it off. And renal TB, again, is a very less commonly known cause. But in Sri Lanka, of course, because of the TB prevalence, you can mention it because there's some value to it, but then you can just be like, no contact history of TB and no early morning, no long-term chronic cough and early morning fever, stuff like that. So late evening fever, those things. And then family history again, because these tumors, polycystic kidney disease can also present as hematuria because in polycystic kidney, those cysts can break and rupture and cause bleeding. So you can say there's no family history of that and that, renal cell carcinoma. And finally, drug history, just in one statement, you can say no anticoagulants and stuff. And also this one thing I had to mention is rifampicin and this beetroot story. This beetroot story, so like I don't know, from I have met, like so many people don't like us mentioning this beetroot thing because although it's like, technically we can lead, pass out red urine when we eat beetroot, that's not really, like a thing they like when we say. So always like try not to mention the beetroot thing, because once you mention it, they'll kind of like joke about it, or put that came during the history. So better not to mention the beetroot. Rifampicin also, how many people do you know who take rifampicin, right? I mean, you take it for TB and all, but if not, no need to mention the drug history. Okay. So yeah, that's about the history. Then examination. So generally is quite important. One thing is because if he has cancer, obviously because of the cancer tumor effects and all that, you can be cachexic. Also, on the other hand, you can be obese also. That is because obesity is a risk factor for renal cell carcinoma. So although the patient is not cachexic, you can't be like, okay, this one might not have a cancer, because obesity, they haven't really said how it plays a role in it, but then they have found that it could be a risk factor for renal cell carcinoma. To mention it, maybe the BMI, you won't have time to like measure all that, but you can just say obese or not. Then fever, again, at the time of your long case, most likely the patient will not be having fever, because he won't come to your exam in the first place if he has fever. So you can just be like a fever. And then other things are pallor, which is because of the anemia due to paraneoplastic syndrome of renal cell carcinoma, or because of the cancer itself. And facial plethora is another thing, because in renal cell carcinoma, one of the paraneoplastic syndromes are polycythemia. So when you get polycythemia, there's increased red blood, so you can get plethoric. Okay, so that's one thing. Other thing is a virtuous lymph node. That is like common to any carcinoma. If it spreads to the other parts of the body, one of the first nodes which get involved are the left supraclavicular lymph node. That's a virtuous lymph. And then petechiae purpura, that is to exclude any bleeding disorders and stuff like that. And lower limb edema, which I mentioned earlier, that's because of the IVC obstruction. Then you go to the abdominal. Abdominal, it could be the flank mass, which is not always a renal cell carcinoma, because it could be any renal tumor, just like tumor. So you can't, just because you find a flank mass does not mean the patient has renal cell carcinoma. It could be anything. And it could be a cyst of a polycystic kidney disease, or it could be hydronephrosis caused due to obstruction by a bladder tumor causing back pressure, causing enlargement of the kidney. So it could be any of those. And it could be percussible bladder, again, because if it's a bladder tumor, it could obstruct it, cause it to enlarge, expand, and you can percuss it nicely over the suprapubic region and over, even beyond that. Then also the should be rectal. Also, you should palpatency, and you should assess for the tone, because if it's a bladder CA, it can involve the rectum, and it can damage the rectal sphincter. So when you do a PR examination, you will see that the tone is less. So these are like plus points in your examination. I mean, rather than someone who is just saying abdominal examination normal, if you can go into these specific points and say if you get a hematuria case, then they know, okay, this student has actually gone through. So those are things good to those stuff. So yeah. And then finally, non-reducing left-sided varicose. That is because, again, if it's involving the left renal vein, it can cause a left-sided varicose. Okay, then CBS examination, of course, not relevant. BP, not. I mean, BP, you might have hypertension, so you can measure, but then not very important. CNSR is also not very relevant. And I call this cancer examination, because these are things you check for metastasis in any cancer. So, the normal things, jaundice, right hypochondria, tenderness, not pain, sorry, and abnormal breath sounds if it's lung, and scalp lumps if it's bony. So the normal things. Okay, that's it for examination. Then, okay, that's all, guys, for theory and history and examination for a long case. And now I'll go to the theory, which after that I'll talk more about the management part. I hope that's okay. So first of all, renal cell carcinoma. So this is the most lethal urological carcinoma. And I mean, these are, straight from Dr. Angavik Institute. So I mean, credit goes to them. I didn't make this slide. So just, you can, I mean, I read these up from his lecture as well, but then just to give a quick brush up. So here, the TNF staging, we don't really need to know the stage one by one. We only need to know these main things. That is, if it is organ confined, that is again organ confined. Then if it is locally advanced, that could be either within the gerotus fascia or else beyond the gerotus fascia. And other thing is, it could be metastatic. Commonest type is a clear cell carcinoma. And the thing is, I mean, not really important, so I'll not waste time on those. You can actually read up. I'll send the presentation so y'all can, if y'all want, you can read on that. And bladder CA, commonest is the transitional cell carcinoma, because that's the lining epithelium. And again, here, you just need to know the classification of, it could be carcinoma in situ. That is, it only involves the epithelium of the bladder. And Hello guys, sorry about that. Small connection issue. My computer goes crazy sometimes. So, yeah, where were we? We were talking about renal theory behind it. So yeah, just you can read about this. We will not waste much time on this. Just know the bladder CA. You can classify it into carcinoma in situ, organ confined. Again, like above, you can divide into two. That is muscle invasive or muscle non-muscle invasive, which is actually and that is organ confined, then locally advanced, and then metastatic. And upper tract ureteric not really important. Okay, then let's go on to the yeah, we'll talk about the investigation. So investigations, I'll first talk about the investigation general to any hematuria. Then later on, I will go on to renal cell carcinoma bladder CA specifically because actually it gets not complicated, but then it gets a bit confusing if I tell everything at once. So I'll first do it like this. So yeah, hematuria, if a patient is more than 40 years. Now remember when we in the first slide, we said if it's an elderly patient, we do always suspect the first thing is urological CA, urological CA. So always you have to exclude it. So what we do is we do a cystoscopy, basically visualizing the bladder. So remember this point. And the rest of the investigation, you can tailor make it according to the patient you get. If it's like definitely a bleeding disorder is the complaint, which you might not get for surgery, but then in a real life scenario, if you get that, you go along that line. So depending on that, you personalize it according to the patient. Okay. So first of all, you confirm the hematuria to say this is a hematuria because it could be, things like myoglobinuria and, other things can actually present as red urine. So you confirm it. So how you do it is you do a basic urine analysis. So what you check for, red blood cells is the main thing you check for. Like we said earlier, more than 3 per high power field is considered a significant hematuria. So you take that. And you can see other things also in your UFR. So in a long case also, if you not just stop at RBC, and if you go on to say these other things, you actually, show a good impression, have a good impression on the examiner also. So other things are like cast. If it's a granular cast, sorry, glomerular cast, you can get red blood cell cast and dysmorphic red blood cells. And similarly, if it's a granular cast, you can see it could be a UTI causing the hematuria. So you can exclude those. And also in your microscopic examination, you can see cells of the tumor as well. So that implies that the tumor is actually high grade. So if you mention like these additional things, it's actually good. So urinalysis. And then the other associated first line to the basic things we do, that is the full blood count, the serum creatinine. Because why? Because if it's a renal tumor, one thing is it can actually damage the renal structure and therefore the function as well. And sometimes if it's a bladder tumor, it can cause back pressure on the kidney and finally affect its filtration capacity also. So therefore, again, serum creatinine could rise. So that's why we do serum creatinine. You can justify saying why you do it like that. And then urine culture is another thing. Again, not really important. If you suspect UTI and you have to make a baseline like thing, you can do it, but then not really a commonly thing, commonly used test. Okay, so here on we'll do it according to the diagnosis. Then, so renal cell carcinoma. This is the these are the investigations you actually need to remember because more than actually nothing more than this. So if you can remember, it's divided in imaging and then other blood investigations and renal biopsy, it's easy for you to remember. So imaging also, first of all, you have to diagnose a primary tumor. Other thing is once you diagnose that there is a cancer, you have to stage it. So basically, with the two of those. So the first thing you do is a simple, always start from simple, the ultrasound, abdomen, and pelvis. Always mention pelvis because you are trying to exclude a bladder tumor as well here. So the importance of this is you obviously can check the primary tumor. Other thing is if the tumor is less than 1 centimeter in diameter, you can't really exclude a renal tumor. So that's why CECT becomes important. And the other thing is, like we said, you can exclude bladder CA. For CECT abdomen pelvis, it is definitely more superior, but definitely more expensive as well. So therefore, you only do it when you are not really your diagnosis not very reliable and you're on the fence again. You can go ahead with the CECT depending on the facilities available. So the importance of this is not just one kidney. You can actually check the contralateral kidney status, which you can do with the ultrasound also, but then more clearly you can see it in CCT. And in contrast to ultrasound, here you can see the renal vein and the IVC involvement also, because you see soft tissues in the CCT. So always mention it's contrast enhanced, not just CT. Okay. So those two are the main two things. Then for staging, the common things, CCT, abdomen, pelvis. If you have facilities, you can go ahead and do an MRI or even a PET scan, but then you don't really do those much in practice, but you can mention those. Bone scan also only if the history and examination is suggestive of bony metastasis. Okay, so that's for the imaging part. Then you do the blood investigation. So here, this is to exclude those, other paraneoplastic features like full blood count for anemia, polycythemia, the liver function test, again, because the liver can get impaired in metastatic features and stuff. And then these CRP and ESR, they have found that you can actually use this as a prognostic marker, but like you can mention it, but not really proven, but you can like always mention you use it to respond to therapy later on. And finally, serum calcium, because it can cause hypercalcemia as one of the paraneoplastic features in renal cell carcinoma. Okay, so that's it. Then you go for the renal biopsy, which is not routinely done because what Rangaviki says is there are three reasons. One thing is when you take the biopsy, now you know now how the renal biopsy is done. When you take it, you actually take the necrotic center of the tumor. So I mean, there's no point of checking a tissue under the microscope which is necrotic, right? You all what you see is it's necrotic, it's damaged cells, and there's no point of it. So that's why it's not useful. The other thing is renal biopsy is like very notorious to cause bleeding. It's actually like one of the very like not looked upon in pediatrics because of this reason, because kids actually they tend to react differently to bleeding and all that. It's very painful and all. So that's why one of the reasons, like in pediatrics, I think there were some SCQs also asked about how to do the renal biopsy, because you need to know like after renal biopsy what to do and all. So I mean, in surgery of course they won't ask it, but then just have an idea that it can cause bleeding here. And again, other thing is seeding of the tumor. That is, now when you put the needle and when you take it out, those tumor cells which are in the primary tumor, they can get deposited along the way. Actually, sir actually disagrees with this to an extent, but then he says it's possible. So it's always good to mention, that because of these three reasons, you don't go ahead with renal biopsy. Okay. Renal biopsy is done, however, if ablation therapy is planned, because when you do ablation therapy, your renal tumor is destroyed. So you can't really get a histological examination from there on. So if ablation therapy is planned, you have to do a renal biopsy first. And also if you suspect other tumors, or we said there are these, different things. I forgot the names also now, but there's also that in sales lecture that he mentions these tumors, right? So if you suspect those things, you can do a renal biopsy. And also small renal masses, which we'll come to later, will also be, if you suspect that, you can do a renal biopsy. So this is all for renal cell carcinoma, not much. So that's all for renal. Then you go for bladder CA. For bladder CA, again, not three actually, there are more than that. But yeah, mainly imaging is the main thing here. So imaging will, again, start from simple, ultrasound කරනවා, abdomen pelvis, same reasons to diagnose a primary tumor. And also here, bladder CA can cause hydronephrosis and hydrourate. If it's invasive, it can cause back pressure and all that. So to diagnose that, you can do. And also, if there are synchronous upper tract lesions, this word synchronous upper tract lesion කියන්නේ, now we said earlier this bladder CA comes from the transitional cell epithelium. No, this transitional cell epithelium is continuous all the way up until the pelvic calyceal system. So if you get a bladder CA, that means there is a high chance that it can spread and form other tumors along that urinary tract. So until the ureter. So therefore, to detect any other upper tract lesions, you can do an ultrasound abdomen and pick that up. Okay, so that's for ultrasound. Then you do this thing called, some call it CT urogram, some call it IV urogram. Anyway, it's a dynamic study. That's what you need to remember. So now the problem with the problem with CT is, why you don't do CT is because this is something that's asked. Okay, so when you do a CT, it's just one image. You do a screenshot of not screenshot. You take a snapshot of that particular moment in time. You take it and you see what's happening in the kidney and the ureter and the bladder. But then this urogram, what we do is we actually send the dye. It's actually a renal friendly dye because their renal function is compromised. So you send a dye and you check for the filling of these, the pelvic calyceal system, the urinary ureter and the bladder. This is similar to in PEDS. Remember, we did this thing called the DMSA, that scan, where we check for the filling and we take images like sequentially, something like that. I mean, pretty much like that. So what you do is you check for the filling defects. So at each point of time, you see if there is any, sorry, I don't have a picture to show you. I wish I had an included picture, but what it does is, if you imagine an epithelium, like if you imagine a tubal structure, and now imagine a tubal structure with one of the surfaces like irregularly patterned, that means there is a tumor there obstructing the flow of that particular dye through the urine. So that's why you call it a filling defect. Okay. So in that case, that is why CT urogram is much more superior compared to a CT, which will only show you the filling at one particular point of time. I hope I made myself clear. If there's anything, just clarify. Okay. So that's the reason for the urogram. And also, in addition to this, you have the other benefits of CT, which are common to both CT and a CT urogram, that is extraventricular spread. And thing is, you cannot see flat lesions in this CT urogram. But the problem with flat lesions are they are the lesions which are actually very problematic. Not that like we always think the bigger the tumor, the more problematic it is, no. But then in this bladder CA, the flat lesions are the nasty ones. But then bladder, even sometimes the urogram cannot really, see this. That's why we have to rely on something like cystoscopy, because you can see the inside of the bladder and you can actually see the tumor. Okay. And this one point, like you don't need to remember much, but you can see in renal cell carcinoma, sometimes you can see more less than 5 millimeter lesions, which you cannot see in ultrasound. Because earlier, remember, we said you cannot exclude less than 1 centimeter. So the small gap you can actually check from a CT ureter. Okay, that's it. Then flexible cystoscopy. So flexible cystoscopy, now you know the difference between flexible and rigid cystoscopy, right? So flexible, like you can do it in an OPD setting because you don't need to do fasting. All what you give is local anesthesia. And compared to a rigid cystoscopy, you need to put the patient under GA and he needs to fast. And you can't do it in OPD, basically the opposite. So always the advantages of flexible cystoscopy are more. So you can mention that that's why you are going ahead with a flexible rather than a rigid cystoscopy. So here, you can visualize the bladder wall to check those flat lesions and actually see if there's a tumor. But then there's no point taking biopsy here also, because what Sir says is if you take a biopsy, it is only superficial. So I mean, if it's a muscle invasive tumor, taking a superficial biopsy won't really give us much information about the tumor. So actually, it will lead to disastrous effects because we might be under the false impression thinking, oh, okay, it's just an organ confined tumor. We can just do something and blah blah. Like we might not treat the patient properly also. So that's why you have to always, it's no point like taking a superficial biopsy. But you can take a biopsy if you think of a suspicious area. Now, for example, now we said like bladder tumor is not the only pathology that can cause hematuria. In a bladder pathology, it could be something else. It could be inflammatory, it could be damage to a bladder due to previous catheterization or something, and it can cause inflammatory reaction there and cause some pathology there. So if you suspect something other than that, it's always good to take a biopsy, and there's no harm in doing that. And practically, you do take it. Only thing is, like even if you do, there's no point here. So hope you got that point. Okay, so that's for flexible cystoscopy. Then you have this TURBT, that is the transurethral resection of the bladder tumor. Like the name says, through the urethra, you put a cystoscope. Through the cystoscope, this is of course done through the rigid cystoscope because this is done actually under the under general anesthesia. So because of that, you have to rely on the rigid cystoscope. And here you can check the tumor histologic because in this you have to take, like the name says, you resect the bladder tumor. So after resecting the bladder tumor, you can check it under the microscope and see the histology and see if it is muscle invasive or not. And also one really interesting thing which says is obturator shape. Maybe I'm sure like Sir must have done it for every group. So remember he said the reason why we do this under GA is because now when we do this, we are basically using a diathermy. We don't use we just use a diathermy to burn the tumor and resect it off. But when we use a diathermy machine, what happens is it can like stimulate this bladder wall. So when you stimulate this bladder wall, what happens is not stimulate bladder wall. Actually, it contracts the bladder wall. And when that happens, your obturator nerve, in this diagram, that's why I included it. You see this obturator lies in close relation to the lateral wall of the bladder. So when this gets stimulated, this obturator nerve gets stimulated. So what does the obturator nerve supply? It supplies the vastus medialis and adductor muscles. So when imagine a patient who is in that position, suddenly adducts the leg. So adducts the thigh. What happens is your electrode is here, a very sharp diaphragm is here, your bladder is here. Your bladder can get perforated very easily. If the obturator nerve is stimulated, then your thigh gets adducted. So that's the reason you call it the obturator jerk. So to prevent that, you do it under general anesthesia. And the problem with doing it under general anesthesia is, like in any general anesthesia, the patient loses their respiratory drive. So because of that, you have to always make sure you have to mention the patient will be ventilated and will be given full muscle relaxation and will be done under general anesthesia because of so and so reasons, because to prevent obturator jerk and prevent any perforation of the bladder. Okay, so that's how you do TURBT. So the process of doing TURBT, you don't remove one tumor. Obviously you can't remove the whole thing at once, right? You have to remove piece by piece. So you call it the piecemeal resection of the tumor. This is not the ideal way because when you remove piece by piece, like imagine in practical situation, if you cut something like maybe some food or something, if you cut it piece by piece, there's a higher chance of leaving out like some of it behind, right? So similarly, in bladder tumor also, when you try to cut it piece by piece, you can leave a resection, like you cannot ensure complete resection margin. R naught margin, that is complete free, tumor free. You can't really do that here. But the problem is that's the only way we can resect this bladder tumor, because if not, it will be too large to pass it through the urethra and down outside. So you have to do it piecemeal. Okay. And another problem in doing TURBT is there's something called the raw area. So when you remove a tumor, that area is like fresh of blood, and it's like erythema, you remove that partner, so it's like a very fresh area. You call it raw area. So the problem with the raw area is the tumor cells which you remove piece by piece, these things can get newly go and implant in this raw area. So when that happens, there's a more like, it's not just in the primary place. Now there are tumor cells in other places as well. So what we do is we try our best to prevent it, but sometimes we cannot prevent it. So how we try to prevent it is we do two things. One thing is you do irrigation during and after therapy. That's a normal irrigation we do during the things, also the prostate pathologies. So similarly, you do irrigation, and also you can do this thing called intravesical mitomycin. I don't know if some of y'all have seen, we of course in our appointment, there was a patient who was given intravesical mitomycin after therapy. So it's like a blue thing. I'll show you in the next slide. Something like this. There is you can actually use any catheter, but then the commonly used one is a three-way catheter. So what happens is from one side, irrigation fluid. Here you give the mitomycin C, which is the blue color, and the third one is actually connected to the catheter back. So by doing that, what happens is this mitomycin is a chemotherapeutic agent. So when you give the chemotherapeutic agent, you try to remove whatever the tumor cells which were implanted in the raw area. Okay. So other thing is now practically, if I mean, sir might want to know if you actually know this. So he might ask, what do you do after giving mitomycin soup? So what you do is you clamp the catheter. Why you clamp is because you prevent the mitomycin C from leaking out through the urethra once you give it. So it gets accumulated inside the bladder. And you tell the patient to change their position every 15 to 20 minutes. So in 15 minutes, you tell him to lie left lateral. In the next 15 minutes, you tell him or her to lie right lateral. You have to change your position for around 2 hours like that. So that the reason for doing that is because now let's say the mitomycin C gets accumulated here. If you say left lateral, so obviously when you say left lateral, right lateral, it will go to the other side, and it will, because you never know where the raw area was, right? So to ensure that all the walls are covered, you tell the patient to keep changing the position for around 2 hours. Okay, so that's like a practical point you need to do. So yeah, that's from isometric C. Then this is common to both renal cell carcinoma and bladder CA. Because now when you do CECT, now these patients we said have anyway compromised renal function because of this back pressure, destruction of renal tissue, and even excreted production can get accumulated. So if you can mention these additional things when you say that you are going to do CECT to stage the tumor, you can say that you ask for a history of allergy, history of asthma, and also you have to make sure the anesthetist is informed and do the investigations. Hydrate the patient properly before, during, and after the procedure. And when you use contrast, you use as little as possible nephro-friendly. And nephrotoxic drugs should be avoided after you do this thing, because all these patients, I mean, we are dealing with the renal pathology here, right? The urine tract. So because of that, it's always good to mention these so that you actually there's a holistic approach rather than only thinking about the hematuria part. Okay. So that's one. And also common to anything, I'll not go into this fitness or surgery. So FBS, FBC, ECG, to RFT. And also I just mentioned 2D echo is because don't mention it for every patient you get, only if the patient has ischemic heart disease, and if the patient is very comorbid, you can mention 2D echo. But if not, an ECG would do first line. If it's abnormal, maybe you can do a cardiology referral and do the 2D echo. So you can say that. Right. Then we come to management. I hope we have time. I hope I'm not tired or anything. So that's only little, so I can quickly finish it up. Okay. So that is done there. So management. I'll talk RCC and bladder cells separately. So one thing you need to know is in renal cell carcinoma, surgery is always the best option, because they have shown that chemotherapy and radiotherapy both they can be resistant. Mainly locally advanced renal cell carcinoma, they are very resistant to chemoradiotherapy, even metastatic. So always go for surgery. So organ confined now, what you do is you do this thing called a radical nephrectomy. Like in anywhere the word radical appears, you need to remember you take the whole thing out. So similarly here, what you take is you take the whole kidney, which is affected, the perinephric fat, the gerato's fascia, but you don't remove the adrenals. So this could be an MCQ sometimes, I don't know, but then you remove just adrenals are not removed. And you remove this thing in a technique called en-masse technique. That means in derived, I'm not sure the exact language, but then to English, it means you remove it all in one mass. So you remove all together, like, this, there are forensic dissections, or we take the entire thing at once. Similarly, we take this entire, all these structures at once. And then you get this thing called the partial or nephron sparing nephrectomy. This is different to radical nephrectomy because here we only take like a part of the kidney out. And here you do it only if the patient has, like, you're suspecting of familial carcinoma syndrome. And also if the patient has a lot of normal tissue, you can take, because, for example, if the patient has only like a part of the kidney involved with the blood tumor, if, let's say, like less than 1%, there's no point in, removing the entire kidney and, compromising its renal function. No. So it's always it's not our decision to make, but then after referral, after nephrologist and everyone says, they will decide whether they're going ahead with a radical or a partial nephrectomy. For familial carcinoma syndromes, why we do a partial rather than a radical is because now familial carcinoma syndromes can occur anywhere in the kidney. It can occur unilateral, most of the time it can occur bilateral. So since there's a high chance of it occurring bilaterally, imagine now, let's say a patient comes with familial carcinoma syndrome, you remove the entire kidney. And then in like 4 or 5 months, the patient comes to again with hematuria. Now the initially, let's say we remove the left kidney. Now he comes with the right kidney involvement of the same tumor. So now you can't again go and remove the second kidney also, because the patient will have to rely on dialysis and then, renal transplant for the rest of, I mean, even if he's lucky enough to get a renal transplant, he might get, or like that, he's like very dependent for the rest of his life. So that's why we always try to spare as much as possible kidney tissue possible in a familial carcinoma syndrome. So remember, those two are the indications for nephron sparing nephrectomy. Okay. But the problems with partial nephrectomy are these three. One thing is it has a higher risk of bleeding compared to a radical one. So on table, in the operating theater, if the patient bleeds like crazy and you cannot control it, you have to, just, forget about all those, things I said before and just do a radical nephrectomy, because the risk of bleeding and, bleeding to death is higher than, the things I said earlier. So always you have to take consent for possible radical nephrectomy before going for the surgery. It's like how we do, oophorectomy in China, and obviously say when you do for this thing, you have to take for hysterectomy also, something like that. So you have to always take consent for radical nephrectomy. And here you have also the anesthesia time is longer, because compared to just removing the entire thing at once, remove it more slowly, cutting the divisions and all, it will take time. So here you have, if the patient is comorbid and elderly, you don't like, you rarely do it, because, he or she will have to stay a long time under anesthesia. And also here, in case, like once you take that resected sample, you send for histology, in any surgical sample, in that, if you see that there are positive surgical margins left, you need to complete that nephrectomy and maybe, do another surgery just to take that margin off. So you call that a completion nephrectomy. Sometimes you might have to remove the entire kidney as well. So those things are the points you need to know about nephron sparing nephrectomy. And finally, thermal ablation and active surveillance. So thermal ablation and active surveillance, they both have the same indications. That's either if it's a small renal mass or if it's like an elderly patient. Elderly patient, because obviously they're not fit enough for surgery. So you go with something like thermal ablation, which can be done radio frequency, cryo, or microwave ablation. Cannot be in a highly region is a point you can remember, if not really important. Active surveillance is basically you keep on like monitoring the patient without doing anything. For, you do investigations, you do imaging, and you keep on monitoring without doing anything. If there is progression, you go ahead with a radical nephrectomy. Simple as that. Okay. So these are the four things for organ confined. Then we come to metastatic and locally advanced. Locally advanced, I put last because it's like something which is not really asked at all. But metastatic, of course, they can ask in theory, SCQ, anything else. So metastatic, there are four things. One thing is a systemic therapy. So systemic therapy, earlier we said, it's resistant to chemo, this thing. But then, sometimes you have, it is resistant to chemotherapy. So they have like developed a new therapy called systemic therapy, which is immunotherapy and targeted molecular therapy. This is not just the normal chemotherapeutic agents we use in other carcinoma, because they're resistant to that. So here, there are different immunotherapy like interleukins, interference and stuff. You don't need to remember names, just remember the names, immunotherapy and targeted molecular therapy. And then you have something called the cytoreductive nephrectomy. This is also a type of chemotherapy, but then it's not really the chemotherapy, the standard chemotherapy that we use. So that's why you call it even though the word nephrectomy is there, like you might think, oh, maybe this is a surgery, but it's not. It's actually like a agent. It's like chemical agent we use. Why we call it nephrectomy is because now in a metastatic disease, it's spread everywhere in the body, So the word nephrectomy means it removes those kidney, the tumor cells, which are spread everywhere around the body. Not that you're, actually going and you're literally opening up the abdomen and taking the kidney out. So it's like a misnomer, but just remember cytoreductive nephrectomy is a type of chemotherapy, more or less. Okay. And then you can go and do a single mastectomy. That is like single metastatectomy. Then what you do is now, so sometimes like when you do the staging, you can see that maybe only part of the liver is involved or something. So then of course you can, I mean, liver is something which can grow back. So maybe you can, take that part out only. So something like that you can do in certain organs. Palliative measures common to any metastatic cancer. So pain management, I mean, I know you all know, so pain management, those things. If there's ongoing symptoms, you can embolize the feeding artery. So stuff like that you can do for palliative measures. Just to improve the quality of life, you can't really give a survival benefit to those patients. Then locally advanced. So this is in between organ confined and metastatic. That is, if it involves, the gerotus fascia and podduct involved in the IVC stuff, then you can go ahead and do a radical nephrectomy with a resection of the adjacent tissue which is involved, with IVC thrombectomy if it is involved, and without lymph nodectomy depending on the number of lymph nodes involved in the peritoneum. Okay, that's all you need to know about locally advanced. It's like something which is really not talked about much. So yeah, just know it, just, and then follow up of this patient. So this is it for management options. So follow up, you need to clinically follow them up by hematuria, ask history, do an examination clinically. And imaging, what you do is a simple one. You don't, follow up, you don't really need to do CT and all, because one thing is expensive. Other thing is you really don't need to, because you already remove the tumor. So all what you can do is you can do an simple ultrasound and, see really do that. And blood test, remember I said earlier, CRP kind of has a prognostic value, but then again, not very proven. So hence the question mark. But you can mention blood test also as a follow-up investigation. And also, it's good to always end it on a high note, saying you have to care for the kidneys, because if you have undergone a radical nephrectomy, you only have one kidney. If you spoil that kidney also because of not tumor, maybe because of hypertension or nephrotoxic drugs or something, so you are just going to rely on dialysis for the rest of your life. So you have to always tell that you're advising the patient on how to care for the kidneys, reducing NSAIDs and, those nephrotoxic drugs and all that. You just have to, say, just flower it up for that at the end. Right, so that's it for renal cell carcinoma. Then you come to bladder CA. So bladder CA, remember where we stopped? If I go back and show you, we did the ultrasound, we did the CT urogram, we did the cystoscopy, we did the TURBT. We did the TURBT, we got the specimen, and we know the histology also now. So now you know the stage also because you did a CT scan. Now how do you go ahead from here? So again, going back to the classification, it could be organ confined, locally advanced, or metastatic. If it is organ confined, it is either carcinoma in situ, that is cyst, and non-muscle invasive. If it is one of these two, if it is non-muscle invasive mainly, what you do is you don't do anything actually. The commonly used practice is surveillance cystoscopy. Surveillance cystoscopy is, like the name says, you serially do cystoscopy on the patient just to check the progress of the tumor. And if it is progressive, you go ahead and do something on the tumor you remove, which we'll come to later. And then the second option is you can give intravesical BCG, the same BCG we give for this the injection, the vaccination, and the active surveillance. So here what you do is if there is progression, first of all, you can rely on intravesical BCG. And if it is still not resolved into that also, you can go ahead and do a cystectomy. So the intravesical BCG is, however, contraindicated in certain patients. So even though when you do surveillance cystoscopy, you see the hematuria is ongoing, you don't always do it on all the patients. If you have the hematuria ongoing in the sense with progressive hematuria, you don't do it because of this reason. When you do intravesical BCG, remember in mitomycin C, I said you clamp this thing catheter for the agent to remain in the bladder. Similarly, here also you have to clamp it for 1 hour. So you can guess what happens if you clamp the catheter for 1 hour after you give BCG. Again, blood will be there if there's hematuria, and it can cause clot colic. So one thing is it will be painful. Other thing is you won't really get the proper benefit of this therapy if you give it to people with ongoing hematuria. Okay, so that's one reason. Other reason is it can cause accident. If you had accidentally perforated the bladder during the TURBT, the previous investigation, when you give BCG into the bladder, obviously it will leak out of the bladder into the peritoneum. So BCG is known to be toxic to the tissue. So direct contact. And that's the whole reason why we use it as a chemotherapeutic agent, because of its toxicity. So imagine it going and destroying the normal tissue in the peritoneum. It will just dissolve and it will just damage the entire thing. So if you know that there is a history of accidental bladder perforation, you have to avoid giving intravesical BCG in these patients. So I hope that's clear. And then if none of these work, you go ahead and do the last line option, that is the cystectomy. Here, from initially, if it was like high grade and all, you can go straight away go with cystectomy, but then it's always good to mention that you do surveillance, intravesical BCG. And if none of these work, you go ahead and do a cystectomy. Okay. And when before doing a cystectomy, it's always good to stage it again, because in case you have given BCG for a long time before doing the cystectomy, there is a chance that the tumor must have, downgraded, and, it could have, the reduced stage. So always good to say you stage it before doing cystectomy. Okay. Then you have the muscle invasive type. So this is again still organ confined, but muscle invasive. Early it was non-muscle. In muscle invasive, so muscle can the reclusive muscle of the bladder. So when it involves a muscle, what happens is we cannot like, and we have to like sometimes now, clinically some surgeons, they don't really, they now of course they do CT on every patient, but then back then I think, they didn't do it on all the patients. If they think clinically this patient is not, if it's definitely symptomatic or metastatic, then they don't want to rely on investigation because they know it. But so in those cases, I'm talking about back then, now I don't think, but in those cases, if you know the histology is muscle invasive, then you don't have any say, but you have to do a staging anyway. Even if you know that the first person has metastatic symptoms, you have to do a staging, because if it is muscle invasive, you never know how much it has involved the muscle, right? So the treatment changes depending on that. So at this point, you have to do staging definitely. So you can say that. And here, there are only two things. One thing is the radical cystectomy with the ileal conduit diversion. So radical cystectomy, like the word radical appears here, the meaning in males, you remove the prostate as well. In females, you remove the uterus as well. Okay. And ileal conduit diversion means, so we are basically removing the bladder, right? So now the patient does not have bladder. The bladder does not serve the purpose. So you lose the purpose of the bladder. So because of that, the patient can, have, increased frequency, incontinence, and all those complications can come because of the loss of bladder. So what you do is you try to create an artificial bladder. So you do it either from one of two ways. You can do a urostomy, where the patient, it's basically a stoma, like a colostomy, what we see, ileostomy after APR. You have a urostomy. You take the ureters out from the abdominal wall and you connect a bladder there. So that's called urostomy. But to drain this out, the patient will need, single sphincter catheterization and, try to drain it out every now and then. All those stoma complications come here as well. Not entirely, because here is urine, there is feces, but yeah, you get the point. And other option is you can get a neobladder. Neobladder from the person's own tissue, you can make an artificial bladder. So the commonly used tissues are transverse colon, cecum, or ileum, and you basically make a pouch of bladder using that. So again, the patient will actually have a bladder even though the bladder is removed. Okay, so that's a neobladder, one of the two options. So it's always good to mention the complete name, radical cystectomy with ileal conduit diversion. Okay, that's the surgery part. Then you have the radiotherapy part, that's called the EBRT, which we use in certain other cancers as well. So here, you basically, through an outside source, you direct radiation towards it and you try to destroy the tumor. Okay, so once you do radical cystectomy, you have to follow them up with urine cytology every 6 months for 2 years. And clinically, you can, depending on the clinical progression, you can decide on the frequency later on. And you can do an imaging, again, similar to renal cell carcinoma, to check for the recurrence of tumor. Here, of course, there's not much prognostic markers like, CRP and those things, but then you can mention these two for follow-up. Then that is complete for bladder CA. Then, I would, in the sense, complete for organ confined. Then you have the locally advanced and the metastatic. So locally advanced, again, not really much to talk about. You can say surgery plus or minus chemo plus or minus CBRT. Because again, locally advanced is something I think Sir doesn't like to talk about much, so he hasn't really gone much into detail about that. But then you just know the metastatic part. So metastatic part, again, palliative, like in renal cell carcinoma. If the patient has an obstruction because of the bladder tumor and he cannot really, urinate and it's troublesome for him, you can always undergo, or you can always make the patient undergo stenting or nephrostomy. Sage and nephrostomy, yeah, these two are these emergency things when the patient comes with acute retention of urine. Similarly, the same thing we use, just that here we use it as a palliative measure. And also here, if the patient has ongoing cystic hematuria, you do a cystectomy, because sometimes this can, in the long term, give rise to clot colics. Okay. And finally, you can also give systemic chemotherapy, because unlike in renal cell carcinoma, here it kind of has a better response to chemotherapy compared to renal cell. So you can give it, but you never give intravesical, because this is metastatic, right? So there's no point giving something to the bladder because it's everywhere in the body. So it's just, there's no survival benefit. So that's why you can give systemic chemotherapy for metastatic bladder CA. Okay, and then So yeah, it's just upper tract urethral. Before finishing it off like completely, I'll do upper tract urethral carcinoma. AK actually there's nothing much, you just need to know like upper tract involves the bladder, sorry, the ureter, upper ureter, renal calyceal system part, and similar to bladder CA because they share the same epithelium. And investigation wise, again, it's similar to bladder CA where you do a ultrasound abdomen, CT urogram, and here instead of a cystoscopy, you had to go further up. So you call it ureterorenoscopy, involving the ureter as well as the kidney, with or without biopsy, depending on what you see. Then management again, you call this I mean you don't really need to know these. Just wasting time reading this because they don't really ask much about this. Just know as an MCQ they might ask nephroureterectomy done in this thing if at all. But for long case definitely I don't think they'll ask. And follow up again here similar to that you can do imaging and check the follow up. Right, and that's it. And hope it was okay. Actually, the questions may I was out today, so I was gonna hope to do the comparison questions at the end, but I couldn't do that. So maybe if you are okay with it, maybe in like 10 minutes I can try to find some questions and discuss with you all later on, or maybe I can do it on another class after I find a proper set of questions. Just let me know. I mean, on this chat or later on WhatsApp, at least just if you know me, just send a text so that I can do some questions if you all think it's useful. So yeah, are there any questions for? Yeah, I'll send the PPT. I'll send it. Are there any questions y'all have? Can try my best to answer if I know. If not, yeah. Hope it wasn't too fast. Okay, then since there are no questions, then I'll wind it up. Just let me know what the questions if you want it. I can tell Franco and arrange another session. Hopefully, I mean, if y'all are free, we can do something. Okay, guys. Then thank you for listening. Hope it is okay.